Welcome to the next edition of Dr. Twyman's Ask Me Anything. I'm Dr. Twyman, a board-certified cardiologist, and I focus on the early detection of subclinical atherosclerosis, and I help people not have heart attacks and strokes. Tonight we're going a little bit early. I have another obligation tonight with some providers to teach them some of these advanced cardiovascular testing so that they can help their patients out. But I wanted to jump on here and be able to answer your guys' questions weekly like I always have been for at least about the past 4 years or so. So appreciate you guys joining tonight, and I'll answer the questions as we go. All right, what is the most accurate way to diagnose familial hypercholesterolemia before going on a statin? I tend to use the GB Insight panel in my practice. There's other vendors that offer these type of testing that look at the different genes that affect the lipoproteins. But often when people have FH, it's an issue with their LDL receptor. So GB Insight is the one that I go to for that. Somebody asked me, what do I have an opinion on for LASIK? So LASIK eye surgery. Personally, I've never had it. I do wear contacts. I have contacts that have no UV filter, and they don't block as much blue light as other contact lenses. If I want to block light, I wear the glasses. But the challenge with LASIK is that you don't know if you're cutting through some of the neuropsin receptors in the eye, and so you can affect some of your ability to make nitric oxide when you do that. So not a huge fan of LASIK. So if you need corrective lenses, better to use glasses or potentially contacts. At least my opinion as a non-ophthalmologist. What is my current supplement stack? What are my thoughts on creatine and magnesium? I'll take the latter first. Creatine, 5 grams a day, useful for most. When I've taken higher doses, I actually gave myself a side effect, so I haven't been taking it for a while. And probably not taking standalone magnesium at this point, but take magnesium. If you have bowel issues, constipation, you can take magnesium if you have muscle cramps. If you have migraines, if you have inability to have optimal sleep, you can always take a little bit more magnesium. If you got high blood pressure, palpitations, possibly useful to take more. So slow mag, magnesium, L-threonate, probably the most common forms that I would consider. But my supplement stack mostly is about things that improve vascular health. So looking at things that improve nitric oxide availability and support the glycocalyx. So both the calorie products, so vascular and arterial cell, take kylo garlic, take berberine, take some bergamot, but probably will be tweaking my stack. Is it possible to reverse atherosclerosis? If so, what steps would you take? Yes, it is. I've definitely done it in myself in many patients. Is it completely reversible? That's a different question, but you can definitely get it where it's not progressing and you can actually see delipidation of plaques. So I can prove that with my most recent Clearly scan. But steps to take, it's intake versus, inputs versus outputs. You gotta stop doing damage to your arteries before your body can do any reversing. So gotta have optimal nitric oxide and healthy glycocalyx, gotta have low inflammation, and you do have to modulate your lipoproteins. If your ApoB is over 70, very unlikely you're going to see your plaque regressing. So use whatever tool you need to get your lipoproteins that whatever goal your doctors are recommending. Ballpark, the 20th percentile is an ApoB of under 70. A ApoB under 55 is the 5th percentile. But that's one of those test don't guess philosophies. Got to do the right testing to figure out what's still driving your risk for plaque. And there's nearly 400 risk factors that can contribute to plaque formation, and you have to kind of pull on the levers as you find them. Does L-citrulline help increase nitric oxide levels? Yes is the answer, but is it an efficient way to do it? No. The body uses the amino acid arginine in the presence of oxygen and an enzyme called endothelial nitric oxide synthase, or eNOS. It will then convert that to L-citrulline and nitric oxide. There are L-citrulline supplements. Citrulline is found in watermelon rinds. can help some people, but you still have to have a functioning endothelial nitric oxide synthase enzyme for that to work. That enzyme tends to degrade as we all age. So it's not the best way to improve nitric oxide. There are other nitric oxide promoters, lozenges, and capsules that will tend to work better. Is there a number one supplement to support congestive heart failure? If you were going to only pick one supplement, and this would be on top of all optimal medical therapy, including beta blockers, ACE inhibitors, mineral corticoid antagonists, the spironolactone type medications, the SGL2 inhibitors, those are where you would want to start. But if you were going to do one supplement, it would be coenzyme Q10. There's the Q-Symbio trial, I believe, is using CoQ10, and that may potentially help with congestive heart failure. But there's a whole cocktail of supplements you can consider, but you can also look at a lot of the quantum biology things, such as photomodulation, grounding therapies, hyperbaric oxygen. There's a lot of things you can do to improve mitochondrial function. Can you fix a clogged artery without a stent? Depends on where the artery is, quote, clogged and what kind of symptoms you're having. A stent is just a metal tube that props the artery back open, but you generally have to take certain medications to help keep the stent open. Can you fix an artery without it? Yes, but you have to figure out what's causing it, and often you have to have relatively low lipoprotein. So again, an ApoB under 55, an LDL particle count probably less than 700. And if you only have access to a traditional lipid panel, probably an LDL-C under 55. What is the most natural way? It's going to be a bit more challenging. There's probably no easy natural way to, quote, completely unclog an artery. But Kyloic garlic would be something that we consider. There are different nitric oxide promoters that may help. The arterial cell supplement has some data for carotid plaque regression. And then definitely some of the pharmaceutical agents potentially help as well. Can not consuming enough protein actually affect sleeping through the night? I don't know exactly which amino acid you'd be missing. Maybe it's missing tryptophan for that, but I don't think that's a direct correlation. Ballpark, you want about 1 gram of protein per pound of your ideal body weight. I would ideally like to see people stop eating at least 3 hours before bed, but more is better, so that your thermogenic effect is kind of dialing down and you're going to bed colder than hotter. So depends on what time of day maybe that you're eating the protein might affect sleep, but I don't think it's not consuming it causing the problems. So how does oxidation affect cardiovascular disease? Well, oxidation is one of the 3 horsemen of vascular disease that I learned from Dr. Mark Houston. You may have 400 different insults to your arteries, but the arteries can only respond with oxidative stress, inflammation, and autoimmune dysregulation. So you're breathing oxygen, using that oxygen to combust the foodstuffs that you eat to turn into energy in your mitochondria. There's going to be reactive oxygen species when this process happens. That causes oxidation to the surrounding proteins that can also damage the local mitochondria. So oxidation is essentially rusting. You can oxidize your lipoproteins. You can oxidize your phospholipids. That then mounts the immune response. The body thinks there's bacteria in the system, and then the inflammation starts occurring. The oxidation directly damages the glycocalyx, and then more lipoproteins are likely to stick to the endothelial lining. So oxidation that's left unchecked definitely is one of the things that contributes to more and more vascular disease promotion. Question about 5 milligrams of Crestor post having a heart attack with a stent. Any downside to taking it? I assume this means every other day. No, not necessarily, but I can't recommend any dosing schedules to anybody who has an active medical condition. So you have to talk to your doctors about this if you can be on a regimen other than the 5 milligrams daily. But in some people who have more muscle symptoms, sometimes every other day or twice a week, you don't get the same benefit, but you're mostly looking for the reduction of inflammation, plaque stabilization, and lowering ApoB with the statin at whatever dose the person can tolerate. Can heart attacks give a small sign weeks ahead? What can these signs be for women and men? Unfortunately, most heart attacks have no symptoms before they happen. The greatest majority have no symptoms. But if you're going to have symptoms, they may not be that, classic. It may just be fatigue or nausea. If you're having the classic pressure, pain, tightness in your chest, or shortness of breath with activity, that is more stable angina, but it can become unstable where it's happening at less and less activity or happening at rest. But anything that's brought on by physical or emotional stress, that's what you got to be looking for. But you don't want to wait till you have symptoms, of a heart attack. You want to go looking at your arteries before that. So that's where, you're using tests like the CT coronary calcium scan or a CT angiogram, plus minus having the clearly AI analysis, carotid entomomedial thickness scans, smart ABIs, aorta scans, things that are actually looking for plaque in your arteries, not waiting for the symptoms. Why is androgen optimization not the standard of care for endothelial function? I wouldn't know the answer. Why not? I work with many different providers that are offering hormone replacement therapy to patients, and then the patients want to be screened for their cardiovascular care, and they come to me for that. Or if the patients don't have that kind of relationship with another provider, I'm often the first person checking their sex hormones, and when they're in the rock bottom, trying to work on their stress management, their sleep, make sure they're doing significant amount of resistance training, and make sure they're not overindulging in alcohol or THC or something else that's going to break their testosterone, and then putting them in the right path to people who know how to optimize androgen dosing without getting people super physiologic, where then you can get into trouble. It's mostly about estrogen. It's not necessarily so much about the androgen so much for the endothelial function. It's the estrogen component that helps with nitric oxide release. Can the drop of hormones be known to affect women's lipids and arterial function? Absolutely. So women go through perimenopause and menopause, and they start having reductions in their estrogen levels, their cardiovascular risk starts becoming on par with a man's risk. Their blood pressure tends to increase, partly in relation to lower nitric oxide availability. Their lipoprotein analysis changes. They tend to have lower HDL fractions. They have higher LDL fractions. So definitely known risk factors when you go through perimenopause. So don't recommend necessarily hormone replacement therapy just for vascular, protective effects. If you have hot flashes, sexual side effects, brain fog, then maybe there's a reason for you to be on hormone therapy at that stage. But you definitely want to be working with somebody who can keep your levels in the physiologic ranges. Why are supraphysiologic testosterone doses an issue? One of the bigger ones is erythrocytosis, lots of red blood cells, blood becomes more viscous, potential for more microvascular thrombosis. That would be one concern. Depending on what is the dose of testosterone, there's all sorts of other downstream effects. Dihydrotestosterone can make different tissues grow. You may have potentially issues with heart function, if you're on other things that are causing the left ventricle to become hypertrophied. So you want to generally stay in a physiological range. It's never been studied at supraphysiological ranges to be safe from a vascular standpoint. The Traverse study was actually probably underdosed. So you have no idea at supraphysiologic dose what it's really doing to the cardiovascular system. ApoE 3.4, total cholesterol 253, LDL cholesterol 176, 54-year-old female, supplementation for statin, trigs are 40. Okay, well, likely not metabolically ill, not likely insulin resistant, but, just looking at somebody's lipids is basically looking at somebody's eye color. What does it mean? Do you have vascular disease? Do you have already a stent, a stroke, bypass surgery? Do you have family history of Alzheimer's? Are you having signs of mild cognitive impair? Those would definitely make a difference between what you're potentially going to utilize. The ApoE4 carriers tend to not respond as well to statins, but doesn't mean that they're necessarily allergic to them. Maybe you're using a lower dose of it, and you're potentially using something like ezetimibe or Nexletol or PCSK9 inhibitor if you really need to modulate somebody's lipoproteins to lower their cardiovascular risk. But just looking at a lipoprotein assessment, you can't tell exactly what the best treatment option is for that individual. Somebody's asking how they can tell the difference between anxiety-induced heart symptoms or real heart symptoms that need to get checked. Well, it's going to depend on, is there something that, is bringing the symptoms on? If you're just truly sitting at rest, all of a sudden you feel extremely anxious, sometimes that's going to be supraventricular tachycardia or heart rhythm disturbance that's causing the anxiety. So sometimes it's a chicken and egg. The heart rhythms causes a increase in catecholamines that makes you anxious. And then somebody tells you just have anxiety, but you actually had a heart rhythm issue. So it depends on your age. What are your other risk factors? What medications you're on? What supplements? What stimulants or lack of stimulants you're on? Caffeine, nicotine, alcohol. So there's a lot of things that can go into this. But again, it's one of those things. Test, don't guess. So if you really are concerned, you potentially need a heart monitor. Maybe need an echocardiogram to look at your heart function. And then when you have a structurally normal heart and no heart rhythm issues, then your mind may be put at ease. But can't tell you not to get checked out unless you know what that person's backstory is. So that hopefully that gives you a starting point to talk with your local doctors about what to consider. Beet juice can be helpful because of the nitric oxide. Yes, that's the thought, is you're getting dietary nitrates with it. The nitrate reducing bacteria in your saliva breaks it down to nitrate. The nitrites then get swallowed, and then the stomach acid converts it to nitric oxide. So yes, that's how beet juice potentially is helpful at with producing nitric oxide. So somebody say, I've seen studies that say elderly people with high cholesterol live longer. Is that true? Not necessarily, no. You're kind of at the bell-shaped curve at that stage. There are people that have certain genes that protect them from atherosclerosis, and lipids are just one of the things that contribute to atherosclerosis. Perfect examples, my great-grandmother had an ApoE2 allele. She had a loss-of-function PCSK9 gene. She likely had ApoBs in her 40s her entire life, never had atherosclerosis, dies at 106 years old. But there are other people who have high cholesterol as they age. That doesn't necessarily mean they don't have atherosclerosis. They just didn't die from atherosclerosis. So just looking at one metric never tells you the full story. There's also, the same things, like people with lower cholesterol don't live as long. Well, that's probably because they have cancer or something else that's causing their body to be so catabolic. So, lipids are just one thing to look at. You want to look at the arteries. If the person's younger and they got plaque, they probably want their levels lower than where they're at. Mother Nature doesn't care about you living past 40 years old. Cholesterol's in you for a reason. You need your hormones, you need your bile acids, the cell membranes. Cholesterol, particles are helpful for the immune system. So you're not going to die of an infection, hopefully by the time you're 40. But if you live past 40, you're more at risk of developing atherosclerosis. So you probably are going to want to do about something with your lipoproteins if you're between 40 and 80 years old. This is not true. Person says they've heard that statin therapy should not be started in people over 70. I probably would not start the highest dose of a fat-soluble statin on day one with somebody over 70 if they've never been on it. But it's going to depend on that person's case. I've seen patients with calcium scores of 0 in their 80s. Maybe I'm not going to use a statin in that person. They have something else that's preventing them from developing severe atherosclerosis. But if they have, multiple stents, they have a calcium score that's north of 400, definitely statins would be on the table. But there's a lot of other testing I would do first to make sure that it's the right therapy for them. All right, there's a question about my thoughts on bergamot for lowering cholesterol. Bergamot's a weak PCSK9 inhibitor. It's not great at lowering lipoproteins, so if you don't have far to go, maybe you'll get 10% drop from where you're at. So I will use it often in patients if they're intolerant to statins or they just want to try supplements first and they're not high risk. But often I tell them, like, this can be a short trial. If in 3 months your numbers aren't significantly better, you should consider using something more potent than bergamot. Somebody's asking, can MCG be used with these pacemakers? Depends which version of MCG you're speaking of. There's one which is kind of like a EKG, and then there's one that is a magnesium. I'll mispronounce it. I think I actually have it here. If you're talking about the MCG, that is more like a cardioflex stent, which is looking at the magnetic signals coming off your heart. It probably is going to be a little bit more okay, but both of them probably are okay, but I would need to know more about what type of pacemaker and what MCG you're specifically speaking of. Any correlation having high VO2 max can reduce cardiovascular disease? I've heard it described like the VO2 max is like your hemoglobin A1C. It's kind of correlates all your exercise over time. You don't get a high A1C on accident, and you'll get a high VO2 max on accident. So if you have high VO2 max, you tend to have lower cardiovascular disease. But there are cases, just having a high VO2 max doesn't mean that you're necessarily atherosclerotic proof. If you did not, recover well after your sessions, and you have a lot of inflammation, you can still have significant atherosclerosis. Person's asking about what statins tend to have the least side effects. Tends to be pravastatin, but it's the least potent. Livalo, which is the only brand name statin still out there, which is pitavastatin, also has the least side effects. And then kind of the lower dose rosuvastatin sometimes has that. So 5 milligrams once a day or every other day in the right individuals tends to have the least amount of side effects. But in those people, when people are concerned about side effects, I want to know what their ApoE status is. I want to know what their CoQ10 levels, their vitamin D, their thyroid levels are before considering it. And then if they're really into it, doing some genetics like the SLC01B gene, that would determine if statins are probably the best option for them or not. I tell people they're tools, but not everybody can tolerate them. Somebody says that they're curious about my knowledge on HRT and cardiac health. They work with many menopausal women. Yeah, you can message me or you can reach out to me via my website, drtwyman.com. Is it safe to have tachycardia for more than 15 minutes? Unknown, and I can't give one-on-one medical advice in this form. So you have to know what's causing the tachycardia and what the underlying heart conditions are before saying it's safe or not. And then somebody's asking us, can fasting be helpful for atherosclerosis? Probably indirectly, because you're not going to have a lot of oxidative stress when you're fasting, but it's not going to regress the plaque by itself. All right. I think my phone battery is actually fading relatively fast, so I don't want it to skip out on you guys. But appreciate you guys joining an hour early. I have some dinner plans with a group where I'm going to teach them more about some of these advanced cardiovascular labs and imaging so that they can start screening some more of their patients. I'll be back next Monday, 6 p.m. Central Time, and be doing this all again. If you're not already following me on my YouTube page, these videos ultimately are going to be up there. And they'll have AI, make the transcripts so you can kind of skip ahead to the questions. If you asked a question, I want to see exactly where yours is at. And then I'm already starting to record some longer form videos that will ultimately be there. There's going to be a newer membership site coming soon. For those that follow me in my Facebook group, I have not been very active there because, there's some things that I can't say in an open Facebook group, but I can behind a kind of more controlled situation where I can kind of control who's in the groups or not. And that's where I'll put more of the long form content where we'll walk through how do you interpret your own labs, how do you review a calcium score, if you've done a CT angiogram, what does these results mean? If you've had a clearly scan, how do you quantify the soft plaque versus hard plaque, and what would you do about it differently? I'll be able to talk about it in this new membership site, which will be coming up relatively soon. So again, appreciate you guys' time and attention, and we'll see you next time.